I'd like to welcome everybody to the NextGen Healthcare Summit for the year. We're excited to have you guys and to spend your lunch or late mornings with us. Appreciate the time you're spending and to learn with us, and have these three experts in their fields just share their knowledge with us. If you've been with us in some of our events in the past, they've really been in person, and we've decided to make that a virtual event this year with our expanding team and with expanding employer base across many different states. Just felt like a virtual summit was going to be the right fit for this year. So this is the first of three different events. So today we're going to be discussing the value of eliminating wasteful spending and improving healthcare outcomes through direct provider contacts. So before we begin, a couple housekeeping rules. So we like to start off with that. If everybody could please mute your microphones. That's going to obviously avoid distractions and disturbances during this event. And then also we want to encourage questions and answers, but just for streamlining that answer box, we have a logistics team that's going to help filter those questions in toward the end at the appropriate time. And so we're certainly looking forward to those questions, but just use that question and answer box there. Before we get started, I want to take a quick second to thank our sponsors for this event. So if Deanna, you can share our sponsor slide here. We have our advocate sponsors there at the bottom with Unified Group Services, Granite Peaks, RX Health Centers, Stealth Partner Group, Green Imaging, and TPAC. And then we have our title sponsors at the top, TrueRx, eLab, and then Wellbridge Surgical. So thank you so much for all those that sponsor the event. We want to take a quick second to hand it over to the Wellbridge Surgical folks real quick to give an overview of their services and really what they're doing in the market that's really changing the game there. So over to you, Dr. Eric Inman and Jeff Williams.
Yeah, hi. Yeah, thanks a lot. We're proud to be one of the title sponsors here, and both Jeff and myself are from Wellbridge Surgical, and wanted to start off by saying we're two of the co-founders, and what we do here and what we are is a multi-specialty ASC or ambulatory surgery center, and we are an innovator in transparent bundled pricing. And so to kind of break that down by multi-specialty, I mean really any kind of surgical service that can be done on an outpatient basis, meaning same-day surgery. Ambulatory surgery center, meaning we are not a hospital, not connected to a hospital, not even affiliated with a hospital. And with the bundled part, what we mean by bundled is our pricing model is such that you get one price for the surgery. It's all paid in one fee, being the facility fee, the anesthesiologist, the surgeon, implants, all that sort of thing is just in one fee. And so, a lot of talk around surprise bills. We don't believe in surprise bills. We want it to be you to know what you're getting into up front, and so that's what we believe in with the bundles. Transparent, probably the easiest one of those to break down is, we post our prices online. We're very passionate about providing the healthcare consumer, the patient with, or the self-funded employer in this instance, with the upfront knowledge of this is how much the price is going to be, and you know before you have the procedure. Wanted to talk a little bit about what sets us apart. I think we always, Jeff and I always start with concierge and quality. From the moment you step inside to our surgical facility, you realize you're not at a hospital, and you will not be treated like a number. That's a lot of the feedback we get, is that it's a unique patient experience surrounded by not being treated like a number and really special attention given to you. We encourage you to check out our website, www.wellbridgesurgical.com. There's a brief video on there. It can kind of give you a little bit of a visual on what we are here and kind of what I'm talking about when I say these things. But you walk in. That's the in-person, from the in-person standpoint. When we get a referral, anytime a Wellbridge surgical patient comes in, the patient experience coordinator, the navigator, really takes that particular procedure or case into kind of breaks it down and says, hey, this is your diagnosis. You don't just need an ENT, you need a doctor who does a lot of ears, or a doctor who does a lot of noses or throat. We break it down and say, this ENT doctor, while they can do anything, they really specialize in this. They do 500 of these versus 5 of these a year. And so that kind of speaks to the concierge piece. Kind of similar with colonoscopies. We all know what colonoscopies are, but a doctor doing a colonoscopy, there are certain quality measures that are associated with that procedure, and you want that procedure. The reason you're there is you want to make sure that you're screening for colon cancer, and you need to have an adequate exam, and things like adenoma detection rate, things like cecal intubation rate, those things matter, and those are things that both Dr. Panicki and myself, both anesthesiologists who've worked with these surgeons that participate here at Wellbridge over the last 10 to 15 years, working with them, we have the surgeons, the doctors here that we would trust as their family and friends. And so, with this, the referral piece, the concierge piece, that does translate to, we really believe that translates to quality. Superior experience and outcomes are the expectation here. They're the norm. So from the owners to the surgeons, to the anesthesiologists, to the nurses, surgical technicians, sterilization managers, all these people that we've had 10 years plus working experience with on the outside, say at the hospitals, at the other surgery centers. We really feel like we've assembled a team here at Wellbridge to be proud of, and not only do the co-founders share this vision, really all the people that I mentioned really care about providing the superior product to the patients that we have here. Another big difference that we have is our dedication to fair pricing. So I mentioned the bundled pricing above. I mentioned the transparency. How we build our prices is different than how other places do. We build it from the ground up. So we really say, how much will it cost us to get an above average surgeon here? Not just any surgeon, not just paying average, above average surgeon, above average anesthesiologist, above average staff, and then add the supplies, implants, overhead, and then build on a small margin. So while other places may build, just set a charge master price and an arbitrary discount, we really try to be as fair as possible, really dedicated to the free market surgery movement. Transparency, I say that again, that not only means that we show people our prices, it really means that we offer everyone the same price. So recent network came under fire, a major network recently came under fire when patients realized that the self-pay cash price was way below the touted discounts. We're not the same. The self-pay patient pays the same as everybody, whether you have insurance or whether you're in a network. We're very passionate about that. So that begs the question, how to access our services. Like I said, everybody gets the same price, so you can call in, you can inquire via the website. Either way, we're going to work you in here, but because we pride ourselves in allowing equal access to the quality and pricing. But as we all know on this this webinar, we know that the American healthcare system is complicated. So the trick really is how does a self-funded employer grant their employees access and plan members access to our service? And so really think it starts with the advisor, so the insurance advisor. We, as an anesthesiologist, didn't know anything about this whole industry until a few years ago, and have really recognized that the trusted insurance advisor is somebody that the self-funded employers around Indiana lean on to make good decisions for them. They lean on to get them the value, and so you need a broker that is dedicated to getting you value. While not all advisors embrace this, we've been encouraged to find several that do. That's one of the reasons why we're here. Connor is one of them. And while every self-funded company can build Wellbridge into their plan, it takes some time and effort for the advisor to set up that plan and to make a win-win. And so they work with the TPA. steer the patient to work with the TPA to steer the patient towards Wellbridge to get that outcome. The last thing I want to say is, when you work with that advisor, the main thing that we have realized is that to make that win-win, what we call a zero tier brings it all together, creates an incentive for that member to come to Wellbridge and to make that right choice. We're passionate about patients and members being able to make an informed decision, and zero tier is what we say that is. So zero tier would be meaning that the patient does not owe a deductible, does not owe a co-insurance that is waived by the employer. And really just getting started off with this in the last 2+ months, we have one employer that has sent 8 employees here, and was just earlier this morning doing the cost savings on it. The procedures would have cost $50,000 on average at other facilities in Indiana. The price with us was $21,400, and so that's $28,600 of savings. And all that was waived in this instance was the $500 deductible for each patient. So $3,500 investment, $28,000 savings. So that's equates to an ROI of over 700%. And we would love for other employers to get on board and be able to help others in a similar way. And I think I'm over my 5 minutes, so I just want to say that we're dedicated to leading the way in this free market surgical care movement. And feel free to visit our website, contact myself or Jeff Williams, and talk with your advisor.
Thanks, Dr.
Thank you
Inman.
all.
Yep. If you know anything about us, then we are very much advocates of transparency, quality, and cost, and shopping for care. And so what you guys are doing is amazing in our market. And so thanks for joining us this morning.
Oh yeah, thank you.
All right, so we're going to kick this off with a quick poll. So if we can. So the first question here is, have you heard of an employer-sponsored direct primary care program before? So I'll give you a minute to answer it, but while you do, I'm going to introduce you to the three folks that we have here, which we've got an amazing group of folks. So first off is Dr. Alex Lickerman. He's the founder and chief medical officer of Imagine MD, a direct primary care physician's office with 5 locations in the Chicagoland area. He spent the first 20 years of his career as a leader at one of the top academic medical centers in the world, University of Chicago, where he ran primary care for 7 years, taught generations of today's leaders in medicine. There he enjoyed a reputation as a doctor's doctor, caring for many physicians who are themselves today considered leaders in their field, a nationally recognized speaker on the topic of resilience. In fact, his book, The Undefeated Mind, on the science and constructing of indestructible self, details evidence-based steps that one can take to increase resilience. He used this to form the basis of the landmark Resilience Project, where he began that at University of Chicago, but exported it to Imagine MD. And he lives by medicine's most famous aphorism: the secret of the care of the patient lies in caring for the patient. So he counts his tenacity in designing preventive care interventions, managing acute and chronic disease, and making the right diagnosis as his greatest strengths. So that's Dr. Alex Lickerman. We've got the second person here is Mr. Gary Everling. He's the Senior Vice President and Chief Strategy Officer at Hendricks Regional Health since 2013. He's responsible for formalizing their strategic planning process, establishing new mutually beneficial business relationships, market development and expansion there. Is also involved in state and federal legislative initiatives. He's also responsible for establishing greater transparency and accountability. There's that transparency and accountability thing for those people carrying out the company vision and strategy. Prior to that, he was at Ascension St. Vincent in Indianapolis with the responsibility for marketing, business development, and strategy, and most recently, system exec at over business development in Indiana. He's got his bachelor's at Greenville University and his MBA at University of Indianapolis, and spends a lot of time as a panelist in this type of environment, talking about direct contracting and how to achieve strong results. And then thirdly, we've got Brad Rex here. He's the president and CEO at eHome Counseling Group. and it is a premier nationwide telebehavioral health company, and it provides metrics-based virtual mental health counseling services by video, so you can reach anywhere in the country. They rigorously select the best licensed master's level counselors to ensure great outcomes. And they do online assessments to target, care, and measure progress. It's a client-centered approach that has demonstrated effectiveness for both simple and complex conditions with high customer retention satisfaction. Since 2018, he's been on the executive leadership of Project Opioid, a Florida initiative to combat the opioid epidemic. As a former Disney executive who led Epcot over 5 years, taking over the day before 9/11, Brad brings a unique perspective to the behavioral health industry. His prior roles include president and CEO, Foundation Partners Group, where he reinvented the funeral experience using technology and multi-sensory experiences. In addition to multiple corporate roles, he was a nuclear engineer officer on board a ballistic missile submarine during the Cold War. Does it all. Distinguished graduate of the United States Naval Academy, Harvard Business School, author of The Surpassing Life, 52 Practical Ways to Achieve Personal Excellence, and a public speaker on leadership and guest service. So I was going to try and ad lib an intro for all three of these folks, but they've just done so much that I just decided that, their intros speak for themselves. And so there's a lot there, but really the takeaway is that you can see you have three masters in their craft, and they're here to share wisdom, and we hope that we can glean some of the knowledge and how we can better support our employees along the way. So quick here, we've got our results for the poll question. Have you heard of an employer-sponsored direct primary care program before? Looks like we're nearly half and half here. So we've got some opportunities to dig into this and learn a little bit more. So we're going to start with Dr. Lickerman. Can you share a little bit about your experience on both the importance of direct primary care and the impact it can have on a self-funded plan?
Absolutely. Thank you, Ryan. So given that 50% of the folks on the poll haven't heard of DPC, what I think I'll do is start with sort of a DPC 101 and then explain a little bit about my experience and how well this works in a self-funded health plan, especially one that's using a reference-based pricing reimbursement level. So direct primary care at its core is really just a change in payment model. And that's a really important thing to realize because there are a number of practices out there that call themselves DPC, but we have a saying in the industry that if you've seen one DPC, you've seen one DPC, because while the commonality between them all is the way they are paid, what they leverage that change in payment model to do, it can be very different. So in the traditional fee-for-service system, when you go to see a doctor, like a primary care doctor, you pay a fee when you get a service. And in primary care, that service is an office visit. And the issue there, of course, is that because the reimbursement level for primary care visits has actually been held nearly constant since the mid-90s with the Balanced Budget Act, primary care doctors have had to pile patient after patient into their panels in order to survive financially, or they've sold themselves to large hospital systems and now sort of working for the man, so to speak. So it turns out that in the primary care, the fee-for-service primary care world, the average number of patients each primary care doctor has to care for is about 2,400. That explains why, when you call to make an appointment in the fee-for-service primary care world, it takes on average 20 days to get that appointment. And when you get into that office, you wait on average 40 minutes in the waiting room, and then on average, you get 16 and a half minutes with your doctor in the exam room. So 16 and a half minutes might be enough if you had an ankle sprain or a rash or something really simple, but really, if you have an unknown medical problem, if you have a series of chronic medical conditions that need management, if you suffer from anxiety or depression or stress, as so many of us do now, especially since the pandemic, 16 and a half minutes is completely inadequate. It's not even enough for an oil change in your car, frankly. So, what's evolved then is that primary care has become a place people go to get referrals. And even though primary care doctors are trained in a variety of areas and can handle, statistics tell us about 80% of all your lifetime medical needs, literally lifetime medical needs. If they had enough time, they don't. And so they end up referring you out to the most expensive part of the healthcare system. You go to the ER for headaches or ankle sprains. You go to specialists that you don't need to because the primary care doctor, while they may have the training to manage a problem, they don't have the time. So in direct primary care, the model is, rather than a fee-for-service model, it's a membership model. Basically, it's like a gym membership. So you as an individual, if you sign up in one of these plans, I shouldn't say plans, groups, Or if you are an employer who self-funds your health plan and you pay a per member per month fee for your employee on behalf of your employee, is literally like a gym membership. So the idea is, when you join a gym, you pay a monthly membership fee, and the gym doesn't care how often you come and work out or not. You can do it once a year in January and still pay the entire year, or you can come every day, twice a day. It's the same fee. So in direct primary care, that's basically the model. So you pay a monthly membership fee, and whether you are perfectly healthy and use the services of the primary care doctor once a year at an annual exam, or you have a series of acute unknown medical problems, or you have a number of chronic medical conditions that need managing, you come and see your primary care doctor as often or as little as you need. The price is the same. There is no fee per visit, right? Now, why do we do that? The reason we do that is because it enables the primary care practice to dramatically reduce the number of patients each primary care doctor is responsible for. So from an average of 2,400 in the fee-for-service system, and ImagineMD at least, the maximum number of patients our doctors ever are responsible for is 600. It's 1/4 of what you see in the fee-for-service world. What that enables us to do, where do we get that number, right? We actually didn't make that number up. We backed into it by determining first, what should our service standards be? If we were to design a primary care model that truly served the society's needs, what would that look like? What would those service standards be? And what we decided was that new patient appointments should be scheduled for 2 hours, because if you actually have a primary care doctor who's going to practice at the very top of their training, at the very top of their license, they need about 2 hours to do everything that they know how to do with patients. And this isn't just, by the way, taking a full history, gathering your entire medical, history and doing a full physical exam. It's also taking every acute problem you may have going on right then. And then it's also talking about preventative care. There's been an explosion in the medical literature about techniques and really things to do to keep healthy people healthy. But in order to get people to do those things, you can't just educate them. You can't just tell people, quit smoking, and if you're overweight, eat less, exercise more. Everybody knows that, right? You need to have a way to actually coach people and a path to show them how they can actually make those behavioral changes long-term, which is extremely difficult. Well, those types of conversations take time. Well, in direct primary care, that's exactly what we have. We have time. Return appointments, at least at ImagineMD, are scheduled for an hour, and they're typically offered the same day or the next day that a patient calls, and then every patient is given 24/7 access directly to their own physician. Every physician, for example, at ImagineMD has 2 phone lines. They have a direct line and they have an emergency line. And if you call them on that emergency line anytime, day or night, you're going to get your doctor. We don't use mid-levels here, nurse practitioners or physician assistants. It's only academically trained physicians who we give patients access to 24/7, 365 days a year, except when they're on vacation, in which case one of their physician colleagues takes over for them. What this enables us to do now is take care of people to sort of fulfill the promise of primary care in 21st century medicine, where the doctors actually have the time to think, to read in the medical literature, to consider all conditions, all possibilities, and not just settle on the very first idea that comes in their head about what a patient may have. The quality of care is dramatically different. And then with self-funded health plans, especially those that reimburse at a reference-based pricing model, we actually serve as the hub of those plans. So your trusted benefit advisor designs these plans for you, and they have a number of programs that are included in those plans. It may be, for example, patient assistance programs for expensive specialty medications. It may be international sourcing for pharmacy medications. The point is that to make those plans work, you have to have a primary care physician at the core of those plans who understands the mechanisms that are built into that plan. Because if you build those plans, but the employees who are seeing physicians are seeing fee-for-service primary care physicians who don't even know what a summary plan design is, there's no way they're going to begin engaging those plans. They don't even know they exist. At ImagineMD, we consider our job at the point of service to make sure that when we make referrals or recommendations outside of our 4 walls, that we're doing it according to the summary plan design, so that even the very beginning, the conversation we have with patients about, say, referrals to a subspecialist or for an MRI or a prescription medication, we are already sort of setting the swim lanes in a way that follows the summary plan design. So in the end, what happens is, in primary care, in the fee-for-service world, primary care expense is about 3 to 5% of your total healthcare spend. That's really probably too low. And so if you invest in direct primary care, like a company like ours, ImagineMD, you're going to raise that to 10 or 15% of your total healthcare spend. But that's an investment you make, because what ends up happening is when we're at the center of the health plan and we're taking care of 80% of all your employees' healthcare needs in our four walls, which is covered by our monthly fee, and 20% of the time we're referring them out in a way that takes advantage of the plan design you've created, the downstream cost, the largest part of the health plan cost, right? Specialty visits, ER visits, pharmacy, inpatient admission, surgery is cut dramatically. And we have case studies showing, in fact, in one where we cut that cost by 34%, literally hundreds of thousands of dollars. We consider our first job to provide excellent primary care to the employees who come to us. But our second job is to sort of serve, in a sense, as a fiduciary of the plan, to make sure that the plan is used as designed, because when it is, not only does it dramatically improve the quality of care, dramatically reduces the cost of care downstream. And in so doing, it's a win-win for everybody. It's a win for the employees. It's a win for the employer and the plan. It's a win for the physicians who actually are practicing the best quality of medicine of their careers and are actually deliver on the promise of primary care to these employer groups and to the employees and their families. So I think I just hit the 10-minute mark. I'm going to stop there and happy to answer questions when we're ready for that.
Yep. Thank you, Dr. Lickerman. That's great. I'm sure we will have some questions, but from my stance, the value is, the time that you said, 2 hours on that initial appointment, and just the partnership that you're creating, I think is just, there's value in that, right? Because you can catch those conditions earlier and you can address things, and you reduce that barrier of entry for care with the $0 there. So certainly value in it, and the partnership is something that we really want to drive into too. And I'm going to throw it over to Gary Everling here as a partnership. He's one of the best. I've witnessed it in lunch meetings and different things. But Gary, can you tell us a little bit about the value of direct contracts with a facility and really the partnership that brings into the realm of healthcare?
Sure. And I can also tag on a little bit on the direct primary care piece. And Dr. Lickerman, man, you and I must have the same mother, because philosophically that was a wonderful overview of what direct primary care is, and that's exactly what our philosophies are. And I would tell you that having done this for a while, one of the things that you really want to look for, and I didn't think I would get to a place in my career where I would say this has been a problem, but I've seen this as a problem, and just as a warning to all of you out there watching this, is that whoever you choose, whether it be a broker or a provider that's providing direct primary care or a direct contract, because I've had most of mine are very, very high functioning relationships. I've had some in the past where they've been very dysfunctional. And what I would suggest to do is to get everybody on the same page from a simple guiding principle document, where you've got the broker involved, the provider involved. I'd love to have the TPA involved, and of course the employer involved, and where we all agree to share relevant information going forward. Because as Dr. Lickerman brought up, data is really the first part of this. It's really key, and I've had some relationships where data is being willfully withheld, and it's very, very frustrating from a provider standpoint. It's frustrating for everybody. And Dr. Lickerman brought up that everybody can win when it's done really well, and so I'm happy to share with those guiding principles that what we share as a follow-up with that. It's very, very simple. It's a one-pager. I mean, you'd really have to be an unusual person not to agree with most of these, and some of them can be tweaked. But the other thing that I would share is that he mentioned time with the patient. Obviously, is very, very key. As a nuance to that is also access, and access is really hard in a traditional primary care setting. And in our model, one of the things I'm most proud of is that we have a shared wellness center model. So if one employer, traditionally it's been in our market that one employer has their own direct primary care clinic, and that's the only place they have access to. And in many cases, if it's a small employer, they may have only had access of 6 hours a week. Now, all of our employer clients have access to multiple wellness centers. Then they've gone from perhaps 6 hours or 20 hours a week to now over 120 hours of access a week. If they're willing to drive a little farther, access is really key. And so they can get in very, very quickly and have that time that I'm talking about and that Dr. Lickerman talked about. And the third piece of this is alignment of goals for the providers in the wellness centers, to make sure that everybody is rowing in the same direction, we're all in the same canoe. And one thing that I've made a priority with our providers is to their compensation model, how they're compensated is going to be more on not only, it's one thing to say, yes, we made the appropriate referral to get a mammogram, we made the appropriate referral to get PSA or to get their lipid checks or to get their BMI checked. But we start measuring providers on how many of your patients have actually done that. It's key to you've got to be an encourager. You got to have providers that are good coaches. You've got to have a team of lifestyle management coaches that are available for group coaching and individual coaching. So those are three things that I would say really look for in a provider. So it's time, and Dr. Lickman did a great job explaining why that's key, but access is key and alignment of goals is key. The data piece is, look for providers that have actually done something with the data. One thing that we've done, and Ryan is very familiar with this with one of our clients, that, from the standpoint of a diabetes programs and mental health programs, one program in particular is diabetes is the second most expensive chronic disease in America. The first is heart and vascular. And so we do a lot of things in terms of tracking lipids and blood pressure for heart and vascular, but specifically on diabetes, look for providers that have specific programs that identify individuals that are at risk, that have high A1Cs, that have ability to track that, and bring them into a coaching environment. And we're running pilots right now with some employers where the employers are paying, removing access to cost barriers for the medications for diabetes, for the testing instruments and kits for diabetes. Those can be very, very expensive. In fact, the testing kits can be more expensive than the medication. But to remove those barriers and have a way to track that and track the ROI on that. And so, I talked about the shared clinic model is really key. So, the collaboration of provider, employer, broker, and TP, I can't say that enough, that they need to be at the table together and have really clear goals in terms of how they're going to go forward and get aligned behind that and ask the question of how are providers compensated and how are they motivated and how are they involved in making sure that the goals of the employer, which the employer, and Dr. Lickerman brought this up too, the employers are paying, they're paying more per visit, per primary care visit for this. This is an investment for you employers watching this. This is an investment on your part. You're expecting a return on investment on that investment. So make sure that the providers and everybody that's involved, and again, the data is key, is what's been the return on that investment that you're making. And if your team can't provide that information, then make those adjustments, manage it going forward, or find new partners that can do it for you.
Thanks, Gary. I know you've said that several times about the power of a partnership with, the facility and the physicians, and then the employer group and broker, and really having all of those folks pulling in the same direction. We talk a lot about aligned incentives versus misaligned incentives, and having all of those folks pulling in the same direction is such a powerful combination, and you can make some drastic impacts on that.
It's very frustrating because you would think that would be common. But I would tell you that the more I'm into this, and it's been 15 years probably, it's rare to find a really good team like that. And with Connor, these folks are going to find a really good team with that.
Oh, I appreciate you saying that.
Yep, yep. And I'm
So data is key. I've heard some similar themes here. Data, access, some analytics thrown in there, but also want us to broaden the discussion here, right? Because we've talked a little bit about health, physical health, but mental health is also a big piece of that. And it really is, they're tied together. They're not necessarily separate. So I want to throw it over to Brad here to really discuss what they're doing here and how we can incorporate mental health into this kind of partnership model as well.
Great. Well, thank you, Ryan. Thank you, Alex and Gary. Such great comments. And partnership is absolutely key. And once again, we really thank Connor for our partnership as well. So I've been doing this for 6 years, the president and CEO of a virtual mental health counseling company. So I've really had the opportunity to see a lot, and in particular with COVID. If you look at what happened with COVID, we had 3 major effects. We had the physical, which of course was the illness and the death part. We had the financial, which are people who lost their jobs and were relocated. And then we've had the psychological. Now we're kind of getting past the physical, hopefully. The financial, we now got people pretty much fully employed, but the psychological part has had a huge impact and a continuing impact as we go forward. In 2021, 22.8% of adult Americans had a mental health condition. And if you look at the 18 to 30-year-old group, we're talking 33.7%. So overall, about 1 in 5, 1 in 4 adult Americans, but 1 in 3 in that younger age group. And if you think about it, these are your employees. These are the folks who are working for you who have mental health conditions. And it's up to employers to really help them with that. Now, when you look at that as well, less than half of those folks who had a mental health condition actually got treatment, only about 47.2%. So we've got a big issue here. We've got rising numbers of people with mental health, but fewer people getting into treatment. I frequently get the question from employers, well, wait though, if we do mental health care, our costs are going to go up. We have more sessions, more people in care. And it's fascinating. And to Gary kind of mentioned this, if you have somebody who has diabetes and depression together, that person's going to cost you 2 to 3 times more than a person who only has diabetes. Because that depression is going to keep them from checking their blood sugar levels. It's going to keep them from taking their insulin. And so their medical condition is going to be substantially worse. We finally got the answer to the question, is there an ROI on mental health, from Cigna. Cigna, about a year or so ago, took a look at literally millions of claims. And what they found is that if somebody has a physical health condition and a mental health condition, if you treat the mental health condition, you save $1,377 in the first year and $3,109 in the second year in total medical and behavioral health costs. So, if you're looking for an ROI, if you're looking to reduce your overall medical costs, treating the mental health conditions is going to help you to do that. And if you go to your insurance company and you say, I want to improve my mental health care, I want to have higher quality providers, they say, well, we're going to have to charge you more for that. Reference the Cigna study and say, you know what, that's not right. That you should be reducing my costs because my overall medical costs are going to go down. The other question I get all the time is, well, we've got EAP, okay, isn't that enough? And unfortunately, no, particularly when it comes to mental health care. The unfortunate fact is that very few employees actually use EAP programs. Typically, they'll have 1 to 2% utilization. And again, you got 22.8% of your workforce who has a mental health condition. So 1 to 2% utilization isn't going to do it. And frankly, the people who use those programs are often dissatisfied. Typically, they're going to have limited sessions, short sessions, sometimes audio only, and if they're not going to get the care they need, and in particular, it's not going to reduce your medical costs. So what you really need to look for is, how do I get high quality mental health care incorporated into my healthcare plan? You know, so what we're saying here is, you get a high ROI, you improve your retention and your recruitment efforts. Fascinating statistic, 35% of employees said that they put a higher premium on mental health benefits than they do on higher pay or salary. 35%. And many more employees now, particularly in these tight labor markets, are looking for mental health benefits. So, you got this situation, you have the benefits of doing it, recruitment and retention, but people need to get into care, and less than half of them are able to do it. So what I really liked about what Dr. Lickerman was talking about is that a great way to get people into care is through primary care doctors. And, this was a kind of fascinating statistic. I thought, well, how many people go to a primary care doctor with a behavioral health or mental health issue, right? And if you'd asked me before I did the research, I probably would have said, well, maybe like 25%, 1 in 4, maybe even as high as 40%. The number is 75%. 75% of people who go for a primary care visit are going for mental health or behavioral health condition. And so this is the ideal time to capture people and find out if they've got a mental health issue. And if they do, get them into treatment. And so a huge benefit of Dr. Lickerman's program is they can spend the time to take people through. Their fabulous assessments you can do today. We assess every person who comes into our program with something called the M3. You do it in 3 to 5 minutes. It measures 7 different conditions. Okay, depression, anxiety, PTSD, bipolar, substance use, alcohol use, suicidal ideation, and gives you your 4 different risk categories for that. So it's kind of like doing a blood test for your mind. Tools like that are out there, and you should be making those available to your employees to get care. I want to make sure and highlight virtual therapy sessions. Okay, one of the huge learnings that came out of COVID is, prior to COVID, less than 5% of mental health sessions were done virtually. Now it's over 66%. And when you do sessions virtually, they're completely confidential. Your employees don't have to travel to a counselor's office, so they save on absenteeism. It can be done in the convenience of the person's home, okay? And so people can get the care that they need, and they stay in care and get better. The other thing I'd like to highlight is, today we have virtual addiction and PTSD treatment programs. They are a fraction of the cost of residential care. Okay, we're talking like 1/6 the cost. They're more effective, they're completely confidential, and your employees don't need to go somewhere, get checked in somewhere, okay, to get treatment. And so we need to kind of get rid of this whole thought of, well, if I have an addiction issue or I have PTSD, I have to go somewhere for 2 weeks or a month or whatever and be away from my work and my family. No, you can do it completely virtually, and these are fabulous programs. So you should make sure and ask about that, and make sure your employees are aware of it. So basically, my takeaways for the group would be, get a high quality, integrated, direct primary care provider that also provides mental health care and referrals for that tests for it and sends people to care for that. Don't count on EAP for your mental health care. Okay, it can be very good for elder care, financial management, that sort of thing, but don't use it for mental health care. Find a high quality provider, metrics-based, that'll do that for you. Have open and direct conversations about mental health. And in particular, I encourage employers to send their managers to mental health first aid. It's a great program. It helps to teach managers how to talk to employees who may be struggling with their mental health, and do it in the right way. And then, finally, for substance use disorder, make sure your employees are aware that there are virtual programs that they can go to that are completely confidential, fraction of the cost, and is going to help them to get better. I want to use one last minute, if I can, of my time to just share a quick story. Of course, I'm a Disney guy, so I got to tell stories. Storytelling is what Disney's all about. But we treat a lot of veterans. I'm very proud of that through Wounded Warrior Project. And we had a veteran who was being treated by his counselor. And the counselor told us this story. He said, the veteran said, "Can you excuse me for a minute?" They were doing their session, and the counselor said, "Yes, of course, happy to." And so he left the room, came back in with his two young sons, and he put his boys on his lap. And he said, "Boys, I'd like you to meet Mr. Brandon. Mr. Brandon is helping me." The father said, "I know I haven't been the kind of father I should have been for you, but Mr. Brandon is helping me to be the kind of father I want to be for you." And when you think about providing mental health care for your employees, okay, you're not just impacting that employee, you're impacting their entire family, their children, and the whole legacy effect going forward. So as a company, if you want to really improve your purpose and take care of your employees, providing them with quality mental health care can make a huge difference in their lives and in their families' lives. So thank you, Ryan. Look forward to answering any questions you all might have.
Yeah, thanks, Brad. That's wonderful. You know, I think having the flexibility and also intentionality of what you do. You know, one of the things that I had taken away from a prior conversation and didn't strike me necessarily was that sometimes, you know, counseling needs to be done with more than one person, right? You can do family counseling, and I think that there's different aspects of just the virtual with convenience, and then also having the time and access that we've been talking about in all of these different avenues that can really strike that in a different vein and be very impactful. So thank you. All right, so we're going to transition to our second poll question here. And we'll give you a second to answer that. And while we do, we're going to gather some of these questions. So if Deanna, if any questions came in that we have to answer, please let me know.
Yep, you bet. We have a question coming in for Brad. Is the mental health first aid program for managers available through eHome counseling?
No, we don't offer it. You can just go on. It's the organization that does it. It's a learning organization, and just go on their website, and they're happy to arrange it for you. We do strictly mental health counseling with master's level counselors and above, but that's a great program.
Sounds good. And then another question came up for Brad about how does your pricing structure work?
So we have different pricing structures. So we are in network with most of the major national insurance companies. So, you know, Aetna, Cigna, Optum, Humana, United. Then we also do self-funded employers, and we are strictly on a fee-for-service basis. So it's not PEPM. It's only services as utilized. And I think, you know, you would find we're very reasonably priced out there compared to everything else. And in particular, as I mentioned on these, we have virtual addiction and PTSD treatment programs that, you know, if you're spending a lot of money on addiction or PTSD treatment, please give us a call. We can really help you with that a lot.
Thanks, Brad. Looks like we've got the results from poll question 2. And we've got an overwhelming percentage, looks like, well, 18 of 35 think that it's 80%. So 50% thinks that it's 80%. Thoughts on that, Dr. Lickerman?
The correct answer is 80%.
Very good. All right, so another one is there for Gary. What are some key considerations when setting up a direct contract with hospitals from an employee's or employer's perspective, rather?
Well, always lead with quality. Always lead with the quality conversation. If the provider and hospital can't demonstrate the quality, or if they're not at the highest quality tier compared to their peers, feel free to walk away from it. That's the conversation we always lead with, and then culture, and then we can talk about price. And I see there's a question. I don't know if you want me to answer the pricing question also, Ryan, but
Sure.
the short answer is they're all a little different. And the reason, and they are not the same as we would have with Anthem or UHC or Cigna. A direct contract, the pricing really in large part depends upon what the benefit plan design allows in terms of, are they gonna, if nobody goes to the low price, high quality provider, then nobody wins. The employer doesn't win, the employee doesn't win, the provider doesn't win. So if there's enough steerage mechanism there, enough encouragement, enough incentive, then we can get really, we can get very interesting in terms of what the pricing is. So they're all a little different, but they're far and away a long way away from UHC or Cigna or Anthem.
Very good. Thank you. One for Dr. Lickerman. Can direct primary care be implemented on a fully insured plan?
Because that would be just an incremental cost without the chance for downstream savings because you're just paying a fixed premium. So it really works best in self-funded plans, and especially in reference-based pricing plans where the reimbursement level is some percentage above Medicare. Especially because in reference-based pricing plans without direct primary care, there's a tremendous amount of friction that employees or patients will experience in the healthcare system. One of the things we do at ImageMD is dramatically reduce that friction by, as Gary said, doing a tremendous amount of steerage, picking providers, in the beginning who are reference-based pricing friendly, high quality, and then even making sure when the patient gets there, if for some reason they're turned away, as often happens because the person at the front desk doesn't recognize the card, it doesn't have the Blue Cross Blue Shield or Cigna and a United logo on it. We even have our patients call their doctor's emergency lines if they're being turned away, so we can correct the misconception of the office that's turning them away, saying, no, you actually have agreed to see this patient and accept the level of reimbursement of the plan. So doesn't work really, frankly, with fully insured, but with self-insured and reference-based pricing works extraordinarily well.
Very good. Last question for everyone. What's the best practice for a successful launch into an employer market? What are some takeaways from you?
Well, I guess I can go first. Best practice for successful launch. The first thing is you have to pick the right partners. You have to have a fantastic broker like you guys who understands how to put these really unique solutions together. Which should be have at its center a direct primary care practice, and not just any direct primary care practice, but one that focuses on data, focuses on metrics, has a program that really leverages the membership model in such a way that paying the fees does have some promise for an ROI down the line, and then a group that takes your employees in hand and really actually comes to open enrollment as we do, explains the model, introduces the doctors. Then when the open enrollment or when the plan goes live, for example, our doctors call every patient who signed up with them, initiate the relationship. It's a lot of hand-holding, a lot of relationship building, and then reports on a regular basis back to the plan. We have weekly meetings, at least initially, involving all of the players to make sure that we're managing the plan at the level of the individual and at the level of the plan itself.
Yeah, I'll just add in there when it comes to the mental health side, the employer needs to constantly be reminding the employees that these services are available. And, I like to use the example. I say nobody thinks about a plumber until they have a leak. Well, nobody thinks about the mental health services until they have a problem. And so what we see, the companies that get good utilization are talking about mental health in their newsletters and the communications that go out to their employees and saying, if you need help, here's a great resource to go to. So it's very important. You can't just send an email out once and say, hey, go to eHome if you have a problem. You need to be reminding them, kind of like Dr. Lickerman was talking about.
Ryan, the only thing I would add is, those are wonderful recommendations, and sometimes you don't know if you've got the right partner until you're down the road and where the rubber meets the road. And I go back to be very declarative, be very clear early in on the conversations. And again, with the guiding principles that we have, all the individuals, all the groups that need to collaborate on this, if they're willing to sign that and they understand what's expected from everybody going forward, I think your chances of success will improve greatly.
Thank you. Thank you all for your time this afternoon and sharing some of those insights. I think they're pretty powerful. If I had a couple takeaways, I was jotting down while you were talking. You know, I think the main things that I see are the reduction of that barrier to entry, right? We want people to have care and to manage their conditions. And so that's a really important piece along the way. And there's that time component that we've seen mentioned a lot, whether it's the initial visit or you know, having that access to care, the data coordination and analytics. I think that's one thing that is, you know, we talk about data a lot, but so many times it's segmented and it's in very different spots. And so being able to, you know, whether it's have one physician be able to see everything going on for that patient, or whether it's, you know, looking for that ROI and the ongoing, you know, return on some of these things that you're leaning in on, just having that data is so important to just tell the story behind what you're doing and the work that you're putting into it. Cost and quality, it's the thing that pops up all the time, right? Is that we want to help people see the best physicians, you know, at the price point that's right, and then just being patient centric. You know, all these, you know, I sensed it from just hearing these folks talk, just how passionate they are about helping employees and finding the right place in care and pulling in the right direction. And so finding those partners that are patient centric, trying to do the right things is just so important for everything we're doing. So with respect to time, we got just a couple minutes left, but I'll give you a couple of minutes left back in your day. But I do want to, before we sign off, remind you that we have our second session, 2 to 3, coming up here on April 19th at noon again. If you're Eastern time, maybe a little different if you're Central or Mountain or West, but that's going to discuss revealing the secret revenue streams of pharmacy benefit managers and how to eliminate those from your plan. So ensuring that, again, there's no maybe misaligned incentives embedded there that you don't see. Well, thank you all for joining us once again. We hope to see you here for the next session. And if there are any follow-up questions, don't hesitate to reach out, because we'll follow up with you and we can answer those behind the scenes. So don't shy away from asking any other questions. Till then.
Thanks very much.
Thanks so much.
Thank you.
Bye.
Bye-bye.